Hello, I'm Professor Fiona McNicholas. I'm a child and adolescent psychiatrist at Lucena Clinic, Crumlin Hospital and UCD, and I'm delighted to present to you today and help celebrate 30 years of research in St. John of God's. The topic today is overviewing research in the Lucena Clinic. I would like to remind everybody that Lucena has been providing clinical services for the last 65 years, and geographically are currently located in 5 locations delivered by 10 consultants who lead multidisciplinary teams. I took up my position in Lucena in October 2001, 19 years ago, and this was the newly appointed academic consultant post that St. John of God's had aligned with UCD and Crumlin Hospital to develop. And I think that's a testament of their interest and support in research within child psychiatry. We know that child mental health difficulties are common, occurring in about 10% of our youth, that they are impairing, and longitudinal studies attest to the fact that they continue into adulthood. However, alongside that, we're aware that services have been typically under-resourced, underfunded, poorly coordinated, and disconnected. There is a research imperative to continue and ensure best use of scant resources, and to develop and deliver evidence-based treatment delivered in a multidisciplinary fashion that support our young people and their families. We need to strive to continue to identify risk and protective factors for mental illness and aim for early intervention, which we know is cost-effective, not only in terms of monetary terms, but in terms of personal and quality of life for the young person. However, research must add to and not take away from clinical services or the burden of care to those delivering them. With that in mind, we started off in 2001 establishing a Lucena Foundation with clinicians and with administrative support from the director at the time, Mr. Paul Martin and Marie McCourt. The goal of the Lucena Foundation was to raise mental health awareness among public and professionals, to increase access to treatment, to ensure appropriate referrals to CAMHS, and to offer clinical support training to multidisciplinary team members, primary care workers, GPs, and teachers. And all of this to be embedded in an environment that evaluated what we were doing and developed new research. 3 main pillars. The psychoeducation was primarily given by monthly parent evenings, initially focused primarily on parents, but then increasingly attended by other professional groups. The professional training was both formal and informal, covering a broad range of topics, and included academic pursuits like a diploma and a master's run in UCD. And the last area was that of research, translational research, again spanning a broad range of topics, but importantly we wanted to ensure that it was widely disseminated amongst the public as well as in typical academic peer-reviewed journals. After the first 4 years of the foundation, we published a paper after having 5,000 parents attending, each attesting to the value of the events. You can read there yourself the quotes that some of the parents left, where they emphasized not only the content of the presentation, but the fact that it was an opportunity for them during a coffee period to meet with other like-minded parents and receive support from them. We ensured that we had a multimedia dissemination program expertly run by Marie McCourt, and this covered both print media, radio, television, along with publications in lay journals. And we very much were lucky to receive the support of and collaborate with the various support organizations. Professional training was equally well received. We launched, the Department of Education sponsored a national rollout of teacher training over a 2-day event delivered by myself and Dr. Blonit Gavin, and over thousands of teachers attended this over a number of years. Every year we presented a workshop at the teachers' organizations, and we also wrote a book for teachers on general mental health and selective mutism, which was sent to schools, all schools in Ireland, free of charge. We focused with the GP, the College of GP, and developed guidelines, contributed a module on child mental health, and are currently updating the book on child mental health. We worked with the HSE in developing a program for Action Children, which was also launched and delivered to primary care workers. And we have continued to provide significant training for our own CAMHS clinical team members. And we are delighted with the support that St. John of God have always given by way of facilitating attendance at these events. I want to move on and just touch briefly on a number of the specific research projects that we had been involved in, and I'm just going to mention a few. I mentioned in the beginning the fact that we are operating in a world, in fact, where resources are limited, but at the same time demand is increasing. And it's so important to ensure that services are both effective and are meeting the needs of the users. There has been very little research of this to date in Ireland, and we have just conducted a systematic review with Dr. Daniel Leahy, who was also a St. John of God senior registrar and in UCD. We identified in the literature 15 studies that evaluated different components of CAMHS services in Ireland. And it's of interest to note that 8 of these 15 were affiliated with St. John of God's. These included studies that looked at parents and young people's general satisfaction with CAMHS, the psychoeducational events, and services for eating disorders. There were also 2 intervention studies that were published, one on cognitive behavioral therapy group for the Friends program, and another was a waitlist initiative led by Joe McGarry, the 2+1 initiative. In total, there were 280 parents and 146 youth that contributed to these research studies. They included 171 health professionals, and there were 60 people included in the 2 RCTs conducted. The findings from all of them were, once a young person and the family accessed CAMHS services, they were generally positive with the experience. However, they did mention the difficulties with long waiting lists, poor collaboration between professionals and between systems, and that limited their experience of the service. The interventions that were studied were effective, but however, we were aware that more robust methodology needs to increase our ability to evaluate the effectiveness of what's being offered in CAMHS in general. I'm also aware that there are a number of other interventional studies that have been conducted in Lucena that are either currently going through publication or have been submitted. There were just some of the publications from the systematic review. Another research program we developed in St. John of God's was that of eating disorders. And I don't need to remind you that eating disorders is a serious mental illness that has the highest mortality rate, and it occurs in about 5% of young people. The prevalence is considered to be increasing, and there's significant continuity. It occurs typically around the adolescent period, but because that it continues, it goes into the young adult period, hence the importance of transition between services. The first study we conducted in 2009 was eating problems in children and adolescents in Ireland. And this was a very large, methodologically robust 2-stage study that included over 3,000 secondary school children that were initially screened and subsequently had a semi-structured interview, along with a certain number of their parents. The findings were that about 15% of secondary school students had significant concerns on the eating questionnaires, and 1.2% would meet clinical diagnosis. The eating concerns, the higher the difficulties there, was linked with lower quality of life and poorer mental health in other areas. Both parents and youth viewed the media as having a very negative influence on them, and that correlated with the eating psychopathology. The second study, Stigma and Treatment of Eating Disorders in Ireland, was conducted in 2015 and led by Dr. Leslie O'Hara. These were 3 separate studies, a mixed methodology. And again, we included secondary school students, health professionals, and qualitative interviews with young people with an eating disorder, their parents, and their healthcare provider. What we found was that there was significant public, personal, and professional stigma linked to eating disorders. From the school survey, a third of young people expressed eating concerns, which was higher than our earlier study, and half of these had not divulged their concerns to anyone, and if asked, they were unlikely to seek professional services. The healthcare study of 171 health professionals, we established that they had less knowledge on eating disorders when compared to other mental health illnesses like depression or anxiety, or indeed medical conditions such as diabetes. And that there was a perception that they preferred and they viewed other colleagues as preferring to work with this cohort less than with those with other difficulties. There was a lack of an awareness between families and healthcare providers about what eating disorder services were in existence at that time. And there was generally a negative perception of ineffectiveness and inadequacy. In the qualitative interview, we were very acutely aware of the high carer burden to parents, and they felt very much alone and isolated. We're currently running a specialist service in Lucena Clinic, the FBT, Family-Based Treatment Service, alongside all the other CAMHS eating disorder cases that come in. But this dedicated FBT team has been set up as part of the development of the National Clinical Programme for Eating Disorders and the rollout of FBT training. And I'm very lucky to be the consultant involved in that team, staffed by many expert and enthusiastic multidisciplinary team members. We have seen an increasing number of eating referrals over the last period of time. We haven't yet been established an eating disorder hub status, and so do not have significant resources. However, alongside the translational research, we have developed a simple model, which is the standardized integration of medical and psychiatry process in youth with eating disorders. And we run monthly clinics in Crumlin Hospital for those children that are most medically compromised. We're prioritizing ongoing clinical training for our staff, and we're collaborating with Bodywise and the National Clinical Programme. We hope in next year that we will evaluate the simple model. And also we have some new specific research that has been planned. There's been a number of publications in the area of eating disorders, and I'd also like to mention that this research has been replicated in a number of different studies. The insert there is of Dr. Yulia Ziranova, who is also a Lucena senior registrar in her time and is now affiliated with St. John of God in Western Australia. For many children with mental health difficulties, they persist into adulthood, and transition between child and adult services is very important. We know from international research that for many young people, this is poorly experienced and executed. And we were lucky enough in 2010 to receive HRB funding for a transition study, examining both policies across Ireland and from 9 different CAMHS, taking a group of children who had reached the transition boundary and investigating their pathway. What we found was that there was gaps between policy and practice, and of the 62 youth that reached the transition boundary, although the majority were perceived by the clinician to have ongoing mental health needs, only a third of them were referred to adult services, and of those, a quarter refused. Certain disorders, such as ADHD and eating disorders, were least likely to be referred. And I think this is reflected in the national clinical programs that have taken on board these areas and are trying to increase collaboration between services. The Milestone Project was an international European funded study, and that looked at transition across Europe in 8 different countries. There was a cohort study of over 700 young people from 39 different CAMHS. And again, ongoing treatment was perceived by about 62% of clinicians. But what was interesting in that study, that although about 50% of parents and young people felt that they also had ongoing mental health needs, it wasn't always the same group. The agreement between the two was only fair. And in fact, half of the children at the transition boundary were no longer meeting criteria for clinical concern. And this suggests in previous research on transition that the numbers of failed transitions might actually be an overestimate and is worthy of further study. The Milestone Project also developed some transition-specific tools that were designed to help practitioners consider at the transition boundary the need of the young person. And this was the transition outcome measure and the readiness measure. And they were found within the RCT to be effective. I'd like to end by talking about occupational stress, because we have become increasingly aware that this is particularly affecting healthcare workers. Partly because of the excess workload, the emotionally charged environments we work in, and the fact that demand seems to continue to outstrip resources. Clinicians in psychiatry might be more at risk on account of the fact that not only have they to manage their own stress, but they have to manage that of their team members and treat other patients who have mental health difficulties. And they're notorious for finding it difficult to ask for help themselves. So within St. John of God and Lucena, we have conducted 3 cross-sectional studies using the Copenhagen Burnout Inventory as the main outcome measure. And these have been supported by the College of Psychiatry in Ireland and St. John of God's. The table here shows you the 3 studies. The first is in consultant psychiatrists in the CAMHS around Ireland. The second is in all staff, clinical and non-clinical within CAMHS. And the third is within adult mental health services, again, all staff, and led by Dr. Larkin Feeney and Noella Broderick collecting the data. The response rate was about 50% in all of these studies. And what's concerning is that the group with the highest level of burnout was in the consultant CAMHS group, where more than 70% of the group reported moderate or higher levels of burnout. Nearly all the group shared a low confidence in government commitment to investment in services and HSE effectively managing them. There was a sense of unrealistic and negative public perception, and it was of interest that although this applied to all services nationally, within the adult mental health service of St. John of God, they did not feel this applied to their own services, suggesting there was more positive opinion of that. What was of concern was there was a significantly high job turnover intention, in that nearly 50 to 70% of staff had felt in the last 6 to 12 months they had seriously considered changing job. This was correlated with burnout levels, and of equal concern was the fact that many of them would not choose to retrain or stay within mental health services. Within the adult cohort examined, the non-clinical staff were most at risk, both of having higher burnover scores, being least likely to want to stay working within the mental health services, and expressing the highest degree of overcommitment. A thematic analysis from the free text questions highlighted 3 main areas of concerns: staff numbers and skill mix within their teams, funding issues, and that of public misunderstanding. It was a bit of a vicious circle, we understood, where unrealistic expectations of the adult or child in particular services led to inappropriate referrals. This increased the workload on CAMHS staff, who either chose to take the referrals and were aware that they may not have the same effective treatments because it fell outside of the core remit of CAMHS, or they didn't accept the referrals. In both cases, both the referrer and the young person were increasingly dissatisfied. This further compounded clinician distress and demoralization, leading to a risk of occupational burnout, leading to either presenteeism and risks involved in that, or absenteeism. And of course, having fewer staff in the service led to further increased workload for those remaining. This taps into the burnout concepts of exhaustion, ineffectiveness, and cynicism. And these were, in fact, some of the factors in the study that predicted burnout rates. What was also concerning is the fact that few staff members had prior or current burnout training, either in their professional training, on the job, or during the current pandemic. We're now 37 weeks into COVID-19, and we're at the second round of level 5 restrictions. We're aware that the impact of the pandemic is unprecedented, unrelenting, and potentially having devastating effects on the individual, family, and society. This is likely to place significant additional demands for mental health services and on mental health providers. And the 3 studies I've just shown you, which were pre-COVID, already shows to high stress levels within the working group. There is an urgent organizational intervention required, both generic for all staff members and specifically to those that are showing rates of significant stress. There's a need to monitor and evaluate this. And indeed, although we have had a lot of research within Lucina in the last 25 years, I believe there's an awful lot more to follow. Thank you very much.